we start? Glad to be here with my co-chair, Dr. Sarkozy from Brussels. Today we're going to have a couple of presentations and then discussion on the Affera system, which now we've been using for almost a year, I think, in US, so a considerable experience. So I think the first presentation is from Dr. Moussa Mansour from NGH. So Moussa, if you want to start.
All right.
Okay, good. Got it. The Q&A. Okay. Yeah, those are the disclosure, and there you go.
Good day, everyone, and thank you all for attending this session. Andrea, thank you for chairing this session. I'm going to talk about ablation of persistent atrial fibrillation using the Sphere-9 lattice tip pulse field ablation catheter. As you all know, this is a catheter that was approved commercially in the United States a few months ago, and the approval came as a result of the Sphere persistent study. So throughout this presentation, I will talk about, I'll give you an overview of this technology. We'll talk about the catheter. I will talk a little bit about the results of the Sphere-9 study, and then I will show a case, a recorded case that we recently did. So this is the mapping catheter. This is mapping system. So it's an ablation and mapping system, and it consists of two generators. The one is for pulse field ablation, and they are stacked up over each other. You see them on the left side of the screen. And then you have the catheter itself, which is a 9mm sphere. It's self-expanding. It has 9 electrodes in it. And what you see on the right side is a couple of maps obtained with this catheter. And here's a close-up view of the Sphere-9 catheter. It has one central electrode for close unipolar mapping. It has 9 mini surface electrodes integrated with integrated thermocouples and 9mm lattice ablation electrode. The ablation is usually delivered not from each of the 9 electrodes. Ablation is being delivered from the whole sphere as a single unit. So the electrodes that you see there are for recording temperature and electrogram, not for ablations, those mini electrodes. It is an 8 French catheter, so it goes through your standard Achilles sheet or any other 8.5 French sheet. So this catheter allows both mapping and ablation, so it's versatile. You don't need to exchange when you do your map and then when you're ablating. Single transeptal puncture, and I think we covered everything. It's high definition. Because of the size of the electrode, it allows high definition mapping. Here are some preclinical, on the left-hand side, some preclinical some animal experiments or bench experiments showing some of the features of the catheter. So we start with the first one on the left, which is conformability. And it's very soft catheter, so it conforms to the tissue. So when you push on it, it really flattens out. It's a soft catheter, so it is extremely unlikely that you will get a perforation when you push with this catheter because of its large surface area. And it is flexibility, it's safe, it's atraumatic. And then when you see on the middle panel, it's stability. So it kind of grabs to the tissue, and this feature is very important when you're ablating, for example, the ridge between the left-sided veins and the appendage. And on the ICE image, you see the catheter on the ridge between the left superior vein and the appendage, and this is probably a view with the ICE catheter just in the outflow tract of the right ventricle. And it's very easy to capture on ICE, which also makes ablation easier. We talked about this stability. I'm gonna skip those. This is what we just covered. So what you see here is the start of a map. So you move the catheter, it acquires. So the mapping system allows for anatomical mapping, like create a shell of the left atrium. It allows for voltage mapping, and it allows for electrical activation mapping if you're mapping an atypical atrial flutter. So what you see here is the initiation of a voltage map on the left-hand side. And it's fast acquisition, so you wave it through what I typically do, I start with the chamber and then I put it in individual veins, define the floor, the roof of the vein. For the left-sided veins, I pull back counterclock to define the ridge between the appendage and the vein. And what you see on the right-hand side is a propagation map of what looks like a mitral isthmus flutter. So here are some additional features, what you see on your display monitor when you're doing the ablation. So you see an impedance map that you see it on, which was the top left panel with a blue globe. Underneath it is a temperature monitoring. I rely on the middle one a lot. One of the features of the catheters is, we all know that pulse field ablation does not ablate by heating the tissue. But even with pulse field ablation, you get a little bit of temperature increase. And this tiny bit of temperature increase, you can use it as an indicator of contact, if you're touching or not. So you want to see this tiny bit. We're talking about only brief increase in temperature. And you see that on the electrodes in front of you, and this is an indicator that you have contact during your ablation. So these are some ablation lesion depth from preclinical work. So the blue bars are the radiofrequency ablations. The gray bars are the pulse field ablation. And the lesion created with this catheter is flat. So it's not symmetrical, it's not like a surface. It is shallow and wide, which makes it ideal for atrial ablation. But the current, the one you use for the atrium give you a shallow lesion, and it is wide, so covers large atrium. And here is a comparison of the lesion diameter on top and the lesion depth on the bottom. The red bars represent measurements of lesion depth with radiofrequency catheter. The first one is the Q-dot, the one after that is the thermocool, the third one is the Sphere-9, so the same catheter with radiofrequency ablation, and the last one with the Sphere-9 with pulse field ablation. So a couple of things to learn from what I'm showing here. So this is the lesion diameter. First, that the Sphere-9 catheter, whether you use it in radiofrequency or pulse field ablation, is the same lesion diameter. And either one is larger than what you get with conventional catheter. If you look on the one in the bottom, shows that the depth of those lesions are the same, whether you use a conventional catheter or this one, which, in my opinion, is more than adequate when you're doing ablation in the atrium. I'm gonna skip this. So here is the evolution of the different waveform of where the company got where they are in the current waveform. So like any other technology, it went through a couple of changes before they landed on this current waveform, and that was based on doing experiments and then measuring pulmonary vein durability on remapping studies. And after going through a couple of pulses, the third pulse waveform, the third waveform that you see here, pulse waveform 3, is what leads to the current pulmonary vein durability that we use now in the clinical setting. So here are the results from, I started out this conversation by talking about the Sphere-9, this persistent, the Sphere-9 persistent study, and this is the result from it. And you know what? No, that's not it. Actually, this is the first in a human 12 months outcome. This was done in Europe before the Sphere-9 study. So the efficacy was, the audience was shaking their heads, so you saw that before I saw it. So thank you for alerting me to that. So for paroxysmal atrial fibrillation, 78% success rate, 78 for persistent atrial fibrillation. I'm gonna skip through this here. So this, as we mentioned earlier, because of you can use the same catheter for mapping and ablation. You can do it with single transeptal puncture, and you can do the whole thing with only one catheter. And this is the Sphere persistent Afib IDE trial that we completed a few years ago. It was published, I think, at HRS last year, and so 1 year ago. And here are the results. This was a randomized study for persistent patients comparing ablation with the Sphere-9 catheter compared with standard radiofrequency ablation. The top Kaplan-Meier curve represent the success rate with the Sphere catheter. The gray one represent with the control catheter with the thermocool. This study was not powered for superiority, and it met its non-inferiority endpoint, but there was a significant trend towards superiority. If I remember correctly, I think 1 or 2 more patients, it would have met statistical criteria for superiority. And what you see in the bottom are the time. It's showing the efficiency of the procedure. The first panel is energy application time, significantly better with the Sphere compared with the conventional catheter. The one in the middle is the transpired ablation time, again, significantly better with the Sphere. And the last one is the skin-to-skin ablation procedure, shorter with the Sphere-9 catheter. So we talked about this, how it is faster and effectiveness non-inferior with a trend towards superiority. And this is the case we recently did, and I'm going to show you. It's a little bit truncated, but this is a case that we recorded. So the first step, what you see here, is putting the catheter in the left atrium. And we're going to start to collect a shell of the left atrium. You see the ice image on the right lower quadrant there. So we start, as I mentioned earlier, we start by creating a voltage map. You can do that relatively quickly. It really takes a few minutes only to get the map. Are there any questions while the video is playing? Yes.
You want to comment on the quality of the electrogram?
Yeah. So we'll talk about. So Dr. Natali is asking about the quality of the electrogram. I think it's a decent electrogram. It may not be as detailed as you get with a dedicated mapping catheter with, let's say, HD grid, or whether with an octarray, but they are more than adequate to create the map and map atypical flutter. And also they may be a little bit smaller in amplitude, but none of this I found prohibitive, or never had felt the need to pull on another catheter to complete the case. So what you see here, those green dots are pulse field ablation points, which we use for ablating the posterior wall. When we went little anterior, you saw a few points that were in red, and these were done with radiofrequency ablation. So some of you may say, why do you need both? So a couple of reasons. First, for this case from the Sphere study, which we were mandated to do some RF lesion. But even now, I use RF, for example, in the area just outside the left superior pulmonary vein to ablate the ganglionated plexi, because the ablation for autonomic plexi is much better with RF compared to pulse field ablation. So that's an area, for example, you can do with radio frequency ablation. And when you get more posterior, we start again with pulse field ablation. Each lesion is 4 seconds with pulse field ablation and 5 seconds with radio frequency ablation. So what you see there, we did the left-sided veins, and then now we're doing the right-sided vein for ablation. Again, when we get to the roof, sometimes I use radio frequency for a few lesions. You don't want to use radio frequency ablation outside the roof, because even anteriorly here, you can get the phrenic nerve, which you will not get with pulse field ablation. You will get it with radio frequency, but not with pulse field ablation. And then making our way down here on the anterior wall. And as you see, this is really wide area ablation. And when I do wide area ablation like this, it takes only a couple of ablation to ablate the rest of the posterior wall. All right, we're doing a voltage map at the end of the procedure. I don't do that routinely now. We did it in our early experience just to learn about the system. I never had a case that I found communication with the vein after we finish the circle around the vein. In this particular patient, we're doing also a mitral isthmus line. I do it with pulse field ablation. You don't want to ablate posteriorly with radio frequency. And I don't give nitroglycerin when I do mitral isthmus line with this catheter. Never had a problem with it. It takes a little bit more ablation to do the mitral isthmus line than the rest of the atrium. So I hit each area with like 2 or 3 ablation points. As you see here, we did a double line. I am pacing from one side of the line and recording from the other to confirm that we have a mitral isthmus block. So here we're pacing from the distal CS catheter. So it lights up early over there, and you see the activation is going around, and the area closest to the line are late on the other side. All right, and I think that's it for the case. So what you see here, posterior wall is gone, mitral isthmus line. Now we're pacing from the proximal CS and showing the other block from the other side. All right, thank you for your attention.
So Moussa, can I ask you, so how do you select your ablation catheter, let's say between Farapulse and Affera?
Yeah, so I think for, did you guys hear the questions all while, and now we have options, correct? We have Farapulse, we have Affera. So I think if you want to do anything beyond pulmonary vein isolation, whatever you want to do is CTI line, when you do a mitral isthmus line, even the posterior wall, probably this is, in my opinion now, that's the best catheter we have. It may not be, it's not a single shot catheter, so it takes a little longer than what you can do with a Farapulse catheter to do the pulmonary vein. But anything more than just pulmonary vein, this is more effective than anything else. So the versatility it gives you, you cannot find it with anything else. And also the dual energy. So you don't have to give nitroglycerin when you're doing a CTI line with this catheter, because you can switch to radiofrequency ablation.
Any question from the audience? I don't see anything here. Oh, no. Any question from the audience? Yes.
Yeah, I mean, maybe, but probably you don't need to do that, correct? If you're worried about lesion depth, you can hit at the same spot with the same First, I don't think it's a good idea to stack RF lesions on top of each other. This is powerful. You'll probably get, if you keep doing RF, you may get charring. But let's say you want to do pulse field ablation. I think if you do like 2 or 3 in the same spot, you will get more depth if you need to. And then you may have to do that sometime on the roof or the mitral isthmus line. It's a good question. We are not infrequently, when like mitral isthmus line, I hit like 2 or 3 ablations on the same spot, but that's with pulse field. I don't stack radio frequency ablation.
There is also, with RF, there is an option of 5 or 7 seconds. With 7 seconds, you get deeper lesion. But as Moussa said, if you do multiple PFA application, you also increase the depth. So that, I mean, you can choose based on the area you are, what strategy you prefer.
I would also consider scar, the presence of scar. If I know there is scar, probably I would rather do PFA, knowing that the lesion depth is better in scar tissue as with RF.
So everyone can hear me, that's good. My name's Erich Kiehl. I'm one of the electrophysiologists at Centera Health in Norfolk, Virginia. I was also part of the IDE trial, along with everyone else here on the panel. What this 10 to 15 minute talk is going to cover is basically operator learning curve for a new technology. We'll kind of talk through who it might be a new technology for and who it may not be. This is a picture from our very first case we did in the IDE trial. This is what our lesion set looked like. Probably don't stack quite as much as we did in the first case, but we'll talk a little bit about kind of how comfortable that first case was for us here in a second. These are my disclosures. What you'll notice is as the second person, HRS is very busy. Moussa and I have very similar kind of slides before the actual data on the operator learning curve. And it's kind of nice going second because you can highlight the things that you might have highlighted differently with the same slide. So one of the things I'll talk about, with respect to the 8 French catheter as compared to some of the competitors, it allows for kind of different closure options in terms of at the end of the case. Obviously, this is a talk about atrial arrhythmia treatment, but you can imagine a world where you're thinking about ventricular arrhythmia treatment. This would be a much better catheter to take retrograde or transeptal, in theory, in the future. It can actually be done through steerable sheaths or non-steerable sheaths. During the trial, I actually did everything with an SL0 catheter. I don't do that clinically anymore, but that's also an option if you're looking to save money. This is the same thing as before. I won't really show these again. I think it's a really nice slide, though, and I agree that the stability with the catheter is extremely good, not just on the left anterior ridge, but again, thinking forward to the future, you can imagine certain structures in the ventricle, papillary muscles, where this might be a good area. If you put your hand on the catheter, it feels very similar to like a Watchman Flex or a Watchman Flex Pro, and that it should be very difficult to perforate with this catheter, and so you can feel very comfortable kind of manipulating it around, both from a mapping perspective and from an ablation perspective. We'll skip through the videos just because you've already seen them. This is the system. It's very small, which I think is nice. It's mobile. There's a foot pedal, which I know that seems like a small thing, but for me, that's a huge thing. You double click on the pedal to go from RF to PF setting. When you're first using the catheter for the first time, you can actually have the reps put a feature on that we had in the trial where it'll actually put cross lines across the posterior wall if you're on the RF setting. I mean, it shows it clearly on the top of the catheter too, but if for some reason you double clicked and you're on RF and you shouldn't be there, it'll alarm you not to do that. So there's nice safety algorithms put in there too. You can actually pace through the system as well. So in a world where we all kind of have shorter lab staffs, I think around the US, you can pace directly with your Affera rep through the system. You can plug any CS catheter or any pacing catheter you want into the system without any issue. So I'll spend a little bit more time going through the persistent trial in some detail because I think it helps kind of provide context for the secondary analysis that we did that is kind of the point of this talk. I think, Affera, before it was bought out by Medtronic and then Medtronic afterwards, really deserves a fair amount of credit for doing this trial. I mean, if you look at most of the pulse field trials that were done thus far, they start with paroxysmal and they move to persistent, right? They went straight to persistent and they compared it. It wasn't just a single arm study, it was a randomized trial versus what many people would consider to be the gold standard approach, in an SCSF catheter with cardo mapping. And so there's a lot of risk to that, right? If you're wrong and it doesn't show, superiority, non-inferiority, or some sort of trend towards efficacy, efficiency, or safety. And so I think a lot of praise should be given for running this trial the way it was done. These are the results which you've already seen. Just want to comment on a couple of things. So if you look at the control arm, I think we should all be really proud of the fact as a field and EP that we've gotten better at treating atrial fibrillation. If you look back, trials 10 years ago, the persistent arm was maybe 50%, 45%. So the control arm here with index lesions, high density mapping, I think there's something to be gleaned from the fact that even our control arm did really well in this trial. This trial predominantly took operators who were very high volume RF operators with the catheter. So it wasn't like you were taking somebody and giving them a new catheter they've never used and saying, well, you're primarily an ESI operator, so then use the catheter you're not comfortable with. It was really, what is your standard of care versus what is something new to you that you've never touched before. And so to show a delta that wasn't statistically significant because it wasn't powered that way, but you can clearly see a trend after the blanking period between the blue and the gray lines is quite impressive in my opinion. And as you can see, none of the safety margins that safety endpoints that we would worry about were seen in the trial. If you look at the application time, the transpired ablation time, and the skin-to-skin procedural time, what you see is about a 25-minute difference. But remember, this is a randomized control trial that we had to do a lot of things afterwards. And there actually was a fair amount of time from when you isolated the veins until when the time point was over. And so probably in the real world, it's actually not 25 minutes, it's more. Furthermore, in this trial, we actually did a fair amount of lesions, which I'll show you in the next trial, which maybe you wouldn't do in all cases. And so therefore, probably that transpired time would be even more so in terms of the delta of cost of time savings in the real world. And this is what I was talking about. This is kind of a supplemental data table from the actual Nature paper that shows basically 96% of patients in the trial got lesions beyond the pulmonary veins, which is great because in the real world, that's what we do, right? This is more reflective of what the real world looks like. 54% of patients got a CTI line, 34% got a mitral line, and 93% got posterior wall isolation. And so you can see kind of the differences in terms of control versus non-control. So the rest of the talk is just going to focus on this post-hoc analysis that we did. And basically the question that some of the members on the publication committee had was, with new technology, how long does it take for you to kind of reach your steady state in terms of how comfortable you are with the catheter, how quickly you can perform the procedure versus what you've been doing forever and ever? And then is there an efficacy difference the more and more cases that you do? And again, just reminding everyone that everyone was very comfortable with the control arm in this trial. So the endpoints from an effectiveness and efficacy, efficacy and efficiency standpoint were exactly the same as they were in the main trial. What we basically did is we looked at the patients who were enrolled in the investigational side, which was 204 randomized patients plus 31 roll-in patients. If you did less than 2 patients in the trial, it was really hard to judge between case 1 and case 2. We wanted to see more of a learning curve than that. Then we basically just grouped people. If you did 1 to 5 cases, 6 to 10 cases, or greater than 10 cases. Then there was actually a cohort of people that did more than 20 cases. And we asked the question, how did efficiency change and how did efficacy change on the primary endpoint? So this is the data. So basically from an efficacy perspective, if you did 1 to 5 cases, your composite outcome at 1 year was 65%. If you did 6 to 10, it was 75%. If you did greater than 10, it was 80%. We had 3 operators in the trial who did more than 20 cases, and that stayed pretty fixed. So it appeared that there was a learning curve in that your efficacy got better. The lesion sets weren't really different between case 1 to 5 and greater than 10. It's not like you were doing more lesions. They were pretty similar. And so if you look at between case 1 to 5 and greater than 10, there was a statistical difference in terms of the efficacy. Again, small numbers. Overall trial wasn't powered for this, but it did show statistical superiority compared to the control arm at 66%. This is just, it's shown in a Kaplan-Meier form, and you can see the clear curve separation right off the bat. If you look at total procedure time, and this was actually, I think, pretty striking to most of us, but when I think about my actual experience in the trial and my experience since the commercial release, it fits. So basically, by the second case, you reached your steady state. If you were used to using a kind of a focal approach, because if you think about it, this is a large focal tip, kind of not point-by-point approach, but approach. If you're a person that's been used to RF, kind of standard RF approach, this is a very comfortable procedure. So on my very first case in the IDE, I could see the catheter on ice. The mapping was great. Dropped my lead. I went floorless the remainder of the trial. And I think a lot of other operators did that as well. And so really what you see is that 25-minute difference we're talking about happened right away, and for the most operators, because of the trial, it didn't really make much difference. If you looked at the 3 operators who did more than 20 cases, there actually was some additional efficiency benefits the more and more cases they did. And I think in a non-trial format, just like any new technology, you'll get more efficient the more you do it. But I think the take-home points here, and here's the manuscript in Heart Rhythm if you guys want to read it. I don't think it's actually hit the print version yet, but it's available online. So I think the take-home points really are that it's a catheter that if you're comfortable with an RF workflow, it's going to be a very seamless transition for you. I agree. I think it's a better catheter for persistent Afib. And then I'll also add in terms of the question, how do I select cases for this catheter versus Farapulse, because we have both of them. I think if you have a small atrium and you really want to just do the pulmonary veins, this might actually be a better catheter just because of the size of FARAWAVE, depending how much flower versus basket you do. You can get into these situations where you end up ablating more and you got to take out the posterior wall because the catheter is so big. This is still a bigger catheter than an SCSF catheter, but it's small enough that you can be really focal with what you want to do. So I think that's another patient population to think about. Be remiss to not thank my wife and my kids for letting me be here because it's their spring break week, and so it's a big ask for me to be here and away from them. So, all right.
Thank you. Any more questions? So I'll ask you the same question to you. So are you converting most of your cases to Affera, or you're still kind of pick and choosing? How do you do that?
So for us, we ablate at 3 different sites, and we have Affera at our main site, but not at our satellite. So I don't have the option at the satellites, but at the main hospital, as long as there's not competition, because we only have one system now between the operators, we try and pick the cases we think are best suited for it. I tend to pick Affera as my primary catheter.
I have a question to you. So it's what would you recommend after having this experience and looking at this data? How can we help that first 10 procedures? Because the procedure time seems to be the same, still the efficacy is different. How do you think we could deal with that? Do you think we should use maybe more strict settings, or do you have any suggestions for the people who are just starting it for the first 10 cases?
Yeah, I think you kind of have to. There weren't a lot of procedural differences, like I said, between case 1 to 5, 6 to 10, and greater than 10. So we can't really point to that it was the way the lesions were delivered or the number of lesions. I think probably it's a steerability thing and getting used to it. I mean, if you're a person that's really used to lesion index values, right, you don't get that with this. But there are surrogates that are very easy. I mean, I think we'll all agree. The catheter lights up when you're in contact. The temperature sensor, we didn't spend a lot of time talking about that, but there's a temperature graph that goes up, and you very quickly will see when you've got a good lesion and not. So I think probably just focusing on the parts of the technology that are new and not worrying about the fact that the procedure itself is pretty much the same is probably the best advice I could give. There's also a mitral setting. I think we talked a little bit about that in terms of if you want to go anteriorly, say you want to do an anterior mitral line, there's an RF setting for that I think is probably a better setting to use. So that's just my thoughts.
I just have one thing to add. I think it's important to look at, from the pictures that we showed you earlier, one was impedance map. So on the globe, you can see the individual electrodes. And it's important when you're touching, that individual electrode would turn into white on that sphere that you see. It's important that you pay attention to that and you make sure that you're really touching before you deliver, because that's your only indicator that you're touching. So that's something, I think it took a couple of cases for me to learn that you really want to make sure you're touching before you ablate.
Question?
Wide area focal PFA.
Can you repeat the question?
Sorry, is there anything more that you would like from a wide area focal PFA catheter?
Anything more?
Elaborate a little bit.
So in terms of Affera, it's a wide area focal PFA catheter. Is there anything more that you would like for as a feature from this catheter?
Yeah, okay, I get it. Well, I think already this is a catheter that seems to, and I'll answer first, seems to achieve better lesion than what we have, but doesn't mean that they're optimal lesion for every patient. If you get people with hypertrophic cardiomyopathies, and so I think improving the quality of the lesion. I think the most important things right now that's why I asked Moussa, is the quality of the recording that has to improve a little bit, and those are things that should be very easy to fix. But I would like to see also some evolution in the waveform and the maximum depth that we can achieve. I think Moussa showed you this sort of like a double line or lesion. I think actually that's very important. We have seen that if you don't overlap those lesions very properly, you tend to have more reconnection. So if you do just a lesion more distant from each other, you clearly get more reconnection. Consider that with PFA, you have a large effect. It show you the depth, but was the diameter on the surface is much larger, but that's an acute effect. And if you don't really overlap the lesion, you tend to see reconnection. So those are things that might become less of an issue with a device that does achieve more depth. I mean, we have to sort of obviously verify that, but I think probably the electrogram right now is what they need to work more in terms of improving what we see.
So from the efficacy, I mean, in my opinion, and for the efficacy point of view, I think this, in the atrium at least, we are only talking about the atrium. Now, the ventricle, that's a different issue. But in the atrium, from efficacy point of view, we have usually, we have extremely high first pass bidirectional block achievement, not talking about the PVI. I think that's, we are all seeing that. Yeah. So indeed, the diagnostic is the question. Now, I think from what you are seeing is actually what they call a close unipolar recording, where there is so between the electrodes, the interspacing difference, there are microelectrodes. It's about 9 millimeters, so it's it's a large view. So what I think could be beneficial for all of us is that. Also, if you look at the scar setting, there are many parameters that you can change to be able, for example, in redo with a lot of scar. That's the cases that we are using for in Europe to see the small signals and be able to, to gain up the signals a little bit, and also in this large view to see the small conducting channels, which is sometimes challenging. But I would like to say that the activation time of this, which basically are like unipolar, so we see much less fragmentation. There is the activation, local activation time is much more correct on, for example, flutter activation maps, in my opinion, that what we are used to the very high density mapping, where there, noise is also being many times tagged. There is a problem with lots of fragmentation tagging. So from that point of view, I find that if it sees signals, and if you can change a little bit the settings to capture the signals, then I think the activation time tagging and the activation map is actually more correct. I also like very much this propagation vector. We don't need to see actually the colors that much, but if you just see the way how the activity propagates, we have it also in the other system, but I also find that very helpful.
Yeah, I would also add just to the point of the quality of the electrograms that there is a difference, but I think in the PFA era where catheters are bigger, I wonder if it matters quite as much. Because if you think about an alternative, we want to have as best signals as we possibly can, and we want to ablate where the actual arrhythmia is coming from. But the size of the catheter you're ablating with is still going to affect that tissue you're ablating. So if you're ablating with a Farrawave catheter, which is way larger, if you had a better map, you might still be covering a larger area. It still gets you to the region you need to get. And I've mapped since the commercial release multiple bi-looped biatrial flutters that I agree the activation annotation was great. So I think it's perfectly fine, and it's only going to get better. So.
In your experience, if you are ablating anterior mitral line, is there a reason would you choose the longer RF versus just double on the PFA?
So, in general, anytime close to the coronary arteries, I use radiofrequency ablation, except posterior. So if I'm doing, let me back off a little bit. If we're doing mitral isthmus line, I do it posterior in most of the patient because it's shorter, except in patients who have scar anteriorly. And it's common area to have a scar. So if you have a scar, I do an anterior mitral isthmus line. And when I do it, I use RF close to the annulus, and when I go higher up, I use pulse field ablation. Posterior mitral isthmus, I don't use any RF, because even if you're close to the mitral isthmus, you still can get, in my opinion, there's a chance you can heat the esophagus. So anywhere posteriorly, I don't touch radiofrequency ablation.
For the anterior mitral line, for example, I would like to use PF more. Why? Because we do anterior mitral lines if there is a scar, and I said we know that RF less likely to penetrate. One thing, the logic behind. The second thing is that there is a sinus node artery. So very occasionally with the anterior mitral, if you do it to the RSPV, you can, if you do it with RF less than 1%, but you can kill the sinus node artery, and the patient may need a pacemaker. So that's for me another reason to say that maybe to use PFA.
Consider that many of these sort of detail has to be verified with remapping study. So I mean that's something we're learning. Yeah. We have a lot of data with the Farapulse, some data with Affera, suggesting that it's more effective. But those are data that have to be sort of confirming in a larger number of patients. Acute effect with any PFA technology doesn't mean anything. Okay.
Is this in the end of, you think, alcohol injections of the vein of Marshall? Would you say would you get the depth that you need on the ridge?
Yes.
That you don't have to worry about?
Yeah.
That's excellent.
Okay.
There's a question over there?
One more question. Yes.
No, wait.
Erich, I think you said you used a non-deflectable sheath in the trial. Did you change now? Do you use a different sheath?
Yeah, I actually, before we switched to using PFA, I'm a Cleveland Clinic person, and so there's a big cost savings thing. And so I was in an era where I used SL0, and I don't know if I just was slow to change, so I didn't change, and I've switched to using an Agilis now, and it's way faster. I don't know how many people in the trial did that I did, but for me, it's made a significant delta in the time change.
Don't do it. Just use.
Just don't do what I did. But my point is that the reason I mentioned that is the outcomes were great, despite probably using inferior sheath equipment, right? And so I think there's just, you can use whatever is comfortable for you that you like, and I think that's a really nice feature of this system.
I think I agree. We haven't changed. We don't use deflectable, but again, the choose of tool is operator preference. So there are people that love deflectable sheet. There are people that don't. So you have to use what you feel comfortable. I don't think there is a, sort of a rule in what is better, because most of the people in our group don't use deflectable sheet. And we get good results. So I think that's a operator preference. So I would not make that like a must that has to be utilized.